welcome to another episode of the Bleeding Edge of Digital Health. I'm your host, Mike Moore. We've got a real exciting guest with us today. We've got Alessandro Grillini, founder, CEO, CTO of Reyedar, which is a really, really cool company out of the Netherlands. It's a startup company combining eye tracking and deep learning to screen for optical and neurodegenerative diseases. Alessandro, how you doing today?
I'm doing very well. Thanks, Mike, for having me here. It's a pleasure, and yeah, really looking forward for a really nice conversation with you.
Absolutely, absolutely. Well, like all episodes, I always like to say the audience loves to see how the sausage was made, so to speak. What Let's go ahead and kick it off by you just sharing kind of how you came up with this idea and how the company kind of got started. What was the inspiration for it all?
Well, it actually came during my PhD that I did here in the Netherlands. I actually moved from Italy to this country for that specific purpose. And while I was doing my internship in the ophthalmology department, we had to interact a lot with patients, and patients had to undergo many kind of different assessments. And what I noticed was that both patients and doctors were complaining about the exact same device. So every time we had to screen someone for the presence of retinopathies, they were always like, "Oh, do I really have to do this test? Oh, is it really necessary?" And the doctor like, "Yes, please comply with it. It's really necessary to do it."
I don't like
But I
this any
already did
more
it
than you
last
do.
time. Exactly, like, hey, we've been doing this already. We've been through that. It's mandatory, and we cannot skip it. So you have to deal with
Yeah.
it. And then, okay, it was my first time learning how this device works. Is like a perimeter, so a device for measuring retinal sensitivity. And I was thinking, how is it possible that everyone complains about it and no one does anything about it? So I thought, well, I see what some criticalities are. I have some, well, non-existent free time on my hand because when you're doing a PhD, the free time is very limited.
Right.
Not that as a founder gets bad. And then I decided to start to build the first prototype in the evening. I had access to eye trackers, so that's where it came to be. And yeah, that was 2016, the first proof of concept.
And
So it was quite a long time ago.
did you, at what point did you decide, okay, I'm going to go all in on this versus did you finish your PhD while you were working on
Mhm.
this and then decide, okay, I'm going to, um, or did you go do any clinical work, in the interim
Mhm.
what was the workflow there?
Yeah, yeah. In a way, we often hear the terms a spin-off referring to companies,
Yeah.
but I actually had a spin-off of my own PhD research. So I was actually hired for doing something completely different. I was working on theoretical models on how neural populations communicate with each other, but I started raising funds to finance this other line of research. So primarily through research grants because I wrote the first prototype, which essentially was like a very simple version of a perimeter device that instead of using manual feedback uses eye tracking, and with that we got the first preliminary good results, which led to the first small grant. It was quite small, around 120,000 euros, and with that, during my PhD, I kind of hijacked the main project. This side things became the new main project, and then, of course, we did a lot of clinical proof of concept, trying basically seeing what sticks with this new approach. Because one thing is to do perimetry, but then the fact that using eye movement opens the door to many possibilities. And then what happened is we had enough. I had enough material, first of all, to finish the PhD, so I did graduate. And during my last year, I enrolled into an incubator. So I was doing 4 days a week research, 1 day a week incubator, and right after I still had like a position for many years. I had a postdoc contract, like a very comfy postdoc contract for around 4 years, but I decided to quit and then to pursue this full time the beginning of 2020, like 1 month and a half before the pandemic. So
Wow.
time wise could have been better.
Yeah, right. Nothing like being thrown right into the fire on multiple fronts.
Yeah.
I can only imagine how challenging that was. Um, and we'll get into a lot of the different applications and indications and potential indications for the technology. Can you set the stage for us? What was the you mentioned that doctors didn't like gold standards
Hmm.
standard of care, which was
Yep.
perimetry, right? You had mentioned
Yeah.
perimetry. What was the use case? What was the problem that you were trying to solve for when you said doctors don't like this, the patients don't like this? What were the challenges that they were experiencing with
Hmm.
the way this was being carried out before your technology was created?
Yeah, ultimately, both perspectives come down to the same set of problems. So, if you look at how standard automated perimetry, which is the current gold standard, functions,
And
it's based on
and you know what?
psychophysical. Mhm.
I probably should have asked that question. Maybe just give a quick outline or a brief summary of why what perimetry does, so that people can understand,
Mhm.
not only the challenges that are associated with the old standard,
But
but what it,
what
yeah,
it does. Yeah.
exactly.
Yeah, so standard automated perimetry is a method that often comes with their own devices that it's used to psychophysically measure the retinal sensitivity of the human eye. So its main purpose is to check if the visual field of a person is healthy or if it has localized or diffuse vision loss. And vision loss in this case is measured as a reduction in contrast sensitivity. So you have different sources of light, and then depending on how frequent a person responds to this light, then an algorithm can determine how sensitive that portion of the visual field is in receiving this light. And the method itself contains the problem that we are solving, because the goal here is to measure retinal sensitivity. So you have all the photoreceptors that get stimulated, so in different portion of the visual field, and you want to know whether or not they respond properly to stimuli. The way it's currently done with this device, it's with really classical psychophysical methods, which means that I send a repeated stimulus in a precise location, and then I have a binary response from the person.
Yes or no?
Essentially, it boils down exactly: do you see the stimulus? Do you not see the
Right.
stimulus? Yes or no. If you see it, press a button. If you don't see it, don't press anything, which in principle works if you have the ideal testing conditions, if the operator is really trained, if you have plenty of time on your hand, if the patient is trained to do that, because this method has a massive learning effect, which of course affects also the operational efficacy of something like this. In order to have reliable data, you need to repeat the test multiple
Right.
times. But then from a subjective perspective, first of all, it is a subjective test, because if I decide to not comply with the instructions, there is no way that you're going to get an answer out of
Right.
me. But then from a patient perspective, there's also anxiety inducing, because people that are getting there, they know it's up to them to respond to the stimulus, and if they don't respond properly, well, they might get diagnosed with something not really nice. So yeah, it's overall like an unpleasant procedure.
And I'm guessing this is done via a big piece of capital equipment,
Yeah,
which is obviously expensive and outdated from a
significantly. Yeah.
technology perspective, etc.
Yeah, yeah, no, no, absolutely. It's quite bulky and expensive, which is another of the problems that we're trying to solve. Although this is less clinical and more operational.
Right.
The fact that a device like this, it's so expensive, cumbersome, and it makes it not accessible outside an hospital context. So you can't really use it for screening. You can
Got
only
it.
use it when the person is already referred there, which in case of certain retinopathies, it's often too late. So it's
Right.
both a clinical issue, like a very personal issue from a patient perspective, a methodological issue, and an operational issue.
Yeah, and especially here in the U.S., I'm sure it's similar abroad and in the EU and whatnot. But we're getting more and more focused on early diagnosis. Low readmissions, all of the, I call them the Obamacare talking points,
Mhm.
where you want, if you can diagnose that patient much earlier on, there's a much lower cost to treat that patient typically over the course of that patient's lifetime versus
Absolutely.
when it's too late, and the patient's obviously they've got an official diagnosis and it may be a significant one, so that makes perfectly good sense. What let's jump into the tech. I know you've got a physical example of the technology, but I'd also
Mhm.
love to maybe you had mentioned you had a video that you thought might be able to be a
Yeah, no,
good
no,
outline.
absolutely. Yeah, yeah. Let me quickly put on the screen. There you go. So what we have developed is a dual device. It's two components, like a wearable one that you can see here in the glasses, and a central hub which contains the processing unit, the screen, and that's where the stimulation comes from. So what we ask from the patient essentially is just to wear the glasses and then to look at what happens on the screen. And the stimulus look like something like this. It's going to come up in really a second. Actually, I will pause. So it's a very simple stimulus that doesn't change in contrast. It's actually as simple as it gets. That moves according to a very precise trajectory that took several years to design to be sure that elicit all the right kind of eye movement. But it's designed in such a simple way that it's completely independent from cognitive capability, attentional capability, cultural
Yep.
background, educational level. It's as aseptic as it can be. So it's really not influenced by basically anything.
Yeah, it's agnostic to any
Yes,
demographic type factors or whatnot.
exactly.
Yeah. Oh, that's fantastic.
Yeah. So yeah, and the whole device
So
is actually what you see here.
so
So
when
it's
when
very
when
thin.
somebody purchases the device, they get a set of the glasses, the terminal, and then the
Hmm.
software, which you guys are building on an ongoing basis. And we can kind of get into some of the deep learning and whatnot that you
Yeah,
guys are going to be
yeah,
putting
yeah,
into the
exactly.
device. But
Yeah,
this is
there.
all one unit, and this is something that could be purchased in an office, in a clinic. Obviously, the hospital could purchase units like this, but it's definitely not limited just to the hospital environment, right?
Yeah, no, 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 absolutely. Actually, most of our launching customers are optician stores, like really your the store that you have down the street.
Lens crafters
Usually
or
it's like a
whatever.
yeah, like usually like high-end shops that they really care about not only selling glasses but also provide like extra service to their customers. And the device is designed like this also to minimize the amount of desk space that it takes. It can even be wall mounted in case you really don't have any centimeter left on your desk.
Oh wow,
So
that's incredible.
it's really designed with the office with the end office in mind. Yeah.
Yeah, no, that's great. What and do you have a physical device so that
Yeah,
people can kind of see?
I actually have it. I have it here. So yeah, in here we have like a specimen of the device, which it looks like a very simple pair of glasses because effectively it is a simple pair of glasses, but it comes with some particular feature. So first and foremost, what the lenses that you see here, they are magnetically attached, so that we don't need to use the glasses of the patient, but we provide the set of lenses, which is included in the whole product
Right,
that we provide, and it also comes with its own occluders for doing the test monocularly. So again,
got it.
this removes the need of patching because again that can be uncomfortable for patient. But yeah, the actual device is something like this.
So that's the camera
On the
on
front
the
side,
yep.
there are three cameras. So the one on the front side is what it's used to communicate with the device that is
Uh-huh.
with the hub, and we
Yep.
use this as a way to avoid the need of having the patient immobilized. So the patient can
Ah,
actually be relaxed and free, and we can correct
versus
in real
having
time.
them rest on their
Exactly.
chin
Yeah.
on the device. That's part of what's so uncomfortable about that test is I've
Also,
actually taken it. Yeah, it's tough to sit there for a period of time.
I mean, and you're a young guy. Try to convince an 8-year-old that has to sit there for like half an hour, and is not
Right.
going to like it. And
Right. Right.
or children. I mean, because
That's a big
unfortunately,
one.
also children need to be tested, and well, it's difficult to force them to sit still for a long period of times doing a very boring thing, which is just pressing a button when a light appears. So
Yep.
with the system, we avoid that complication, and the test is much more comfortable. And it also automatically calculates the distance from the device. So in order to adjust the person, you can just literally moving back and forth. And then the other two cameras, the ones that you see here, like the smaller ones,
Yep.
these are very small infrared cameras that are pointed towards the eye, and they sample the eye image around 200 times per second. So they're small but quite powerful,
Mm.
and that's what we use for the gaze estimation.
Ah, got it.
Mm.
And what? So the first indication you're going after is retinal sensitivity, right?
Yes, that's the first thing
Okay.
that we're measuring, mostly related to glaucoma and other retinopathies.
Got it. Got it. And then, and any advanced ophthalmic diseases that you think you'll be able to measure in addition to just retinopathy and glaucoma, AMD maybe, or
Definitely. Pretty much anything that has a direct repercussion on the integrity of the visual field. So, AMD is definitely one of them. Diabetic retinopathy is another
okay, yeah,
big
that's another
example
one I was
because the
thinking.
prevalence is quite high. Also, maybe less common disease like retinitis pigmentosa, which affect selectively the periphery. That they're quite easy to detect
Mhm.
in this way. So yeah, pretty much all classes of conditions that have localized visual defects. That's really our sweet spot at the moment.
And then forward looking, what, we've talked to, offline a little bit about
Mhm.
some of the neurodegenerative stuff. And
Oh yeah,
I love on the website, it says, the eyes are the window into the brain because there's such a direct connection there. So can you talk a little bit about what you guys are working towards with that?
oh yeah. Actually, this already started during my PhD because one of the first application of this method that we call SONDA, so it stands for Standardized Oculomotor and Neurovisual Disorders Assessment. So quite a mouthful. So SONDA, it's short and sweet.
Yep.
It means a satellite in Italian. The thing that you send in the space. That's called
Yep.
sonda.
Got it.
I like that one. And during my PhD, we tested two types of neurodegenerative conditions: multiple sclerosis and Parkinson. And we saw that we were able to have like a very clear separations between healthy and unhealthy with this kind of system, but also to go much in depth to search for very specific symptoms that are often present in these conditions. I give you a practical example. If we take multiple sclerosis, it's a very heterogeneous disease, can have many different symptoms and complications. And one complication that is present in around 30% of cases, it's called the internuclear ophthalmoplegia. And it's quite difficult to measure objectively, to
Right.
quantify objectively. You can see that it's there, but to measure objectively the severity of it, it's quite difficult to do non-invasively. And with something like this, we can perfectly measure binocularly the adduction and abduction level of both eye to see if there is an unbalance. So
Yeah.
this was just like a specific example on a complication of MS, but
I've got
same
I've
apply
got
to
a I've
Parkinson.
got a
Yeah.
close friend from high school was recently diagnosed with MS, and
Mm.
that is it's one of the most challenging diseases because there's no real definitive. It's a really hard disease to diagnose. They kind
Yeah.
of they give you a checklist of six things, and I guess if you have three of them, you've got MS. There's not a whole lot of objectivity to it. So
Exactly.
uh, that would be a huge advantage, especially in that disease state. And
It,
I have
it,
to
it,
believe that some of these other neurodegenerative diseases are similar. I've talked about this a lot on the show. I've got restless leg syndrome, and
Mhm.
there's no test you can take to do you have restless leg syndrome. You just describe your symptoms, and
Mhm.
then they say, it's kind of like IBS, irritable bowel syndrome.
Mhm.
Like if you have gastro issues and they can't figure out what it is, then they diagnose you with IBS. So it's exciting to see, especially Joe Mullings, the CEO of the firm that I'm now with, the Mullings Group. We've talked about this, and the brain is the new heart, meaning that over the last 20 years, 30 years, we've seen logarithmic change with heart disease and devices to treat that. The brain has been kind of relatively unpioneered, and we're learning more as technologies like this come out. We're learning more and more about the brain, which allows us to treat these not only treat but diagnose and treat
Mhm.
these diseases much earlier on and to a greater extent. So yeah, the MS indication is really exciting, or I should say application. No indication yet. Let's be clear. What else? What other neurodegenerative diseases are you guys looking at?
So uh, first of all, I wanted to clarify one thing, that what you say is absolutely true and is a very pervasive problem in neurology that often lacks objective gold standards that are non-invasive, and non-invasive here
Right.
is the key word. So that's really what we are trying to move towards. I can give another practical example. It's still in neurology, but not in the neurodegenerative class. This is a neuromotor disorder. It's a cerebral palsy, so
Mm,
especially pediatric cerebral palsy, so affecting children, is exactly the same problem. There is no shared objective gold standard to determine the subtype of cerebral palsy. Cerebral palsy, again, is very heterogeneous condition, like unfortunately many neurological conditions are, and each subtype has its own treatment path. But if there is no consensus on the subtype, how do you really guess the correct one? And we're talking about children, so if you do the wrong decision, the repercussion is really severe. It's really like life altering for these kids.
sure.
So
Sure.
what we're doing right now is trying to create an objective biomarker that combines different properties. It has movement tracking, like actual limb tracking with the 3D sensors, but also eye tracking and head tracking, all integrated together. And that's where machine learning comes into place, because this is like a humongous amount of data to be analyzed by a person, with the hope of creating a sort of digital biomarker that is a objective representation of the symptoms, even though they're really all over the place, that characterize each subtype of cerebral palsy. So this is one
Yeah.
of the R&D projects that we have right now. In the neurodegenerative space, we are starting now. It's still in the early phase, so I can't really say much. But it's about Alzheimer. So Alzheimer, dementias, other terrible diseases that unfortunately affect many people
So
that we
many.
know. Yeah, I think everyone knows at least one person that suffers from it, and it's really like a devastating
Such an
disease.
such an I don't want to say ugly disease, but it's so difficult to watch somebody go through that, right? I
Exactly.
mean, yeah, it's and the earlier you catch it, there are things that you can do. You can't stop it, but you can, slow the progression of it if especially if it's diagnosed early. That's
Exactly,
where you
and
can.
and, the, and we are going in that direction from a therapeutic perspective, because if you would have talked about early detection of Alzheimer or Parkinson 10 years ago, the answer that you got is like, yeah, cool story, but then there's no treatment. So what's
Right.
the point of it? But now treatment seems to start emerging, and that's where early detection can truly make the difference in the quality of life
That's
of a
right.
person.
That's
So
right.
we're
And
really going in that direction. We don't want to arrive at the point where we have the therapy, but we don't have the way to detect it early, because
right.
otherwise, yeah, we want to start working early on that as well.
And what about you mentioned Parkinson's or
Mhm.
pre-Parkinson's? Is that something that you guys have talked about?
Absolutely, yeah, yeah. We actually have a published study on Parkinson. We did it a few years ago, and again, similar case. Parkinson is often confused with other form of Parkinsonism that are not the exact Parkinson syndrome. And that's where an objective biomarker can come into place. But even more interestingly, one research project that we're starting now in Germany is to trying to look if it's possible to identify oculomotor abnormalities in prodromal Parkinson. So before
Mm,
the disease is fully manifest,
yeah.
which of course will absolutely improve the chances of treatment.
100%. 100%. And you had mentioned one that I don't know how much you can talk about this, but the last time we spoke, you mentioned a project that you guys were either in the works on or considering that I thought was fascinating was
Mhm.
was pediatric oncology.
Oh, yeah, no, no. Actually, this has been going on already for quite a while. And again, this is not a it's not a fun topic. Absolutely, like children with cancer is probably one of the worst combinations that you can have, and they really suffer also from the method from which they are tested. Like if you want to measure their residual vision, no, taking a step back, when we're talking about cerebral tumors, it often happens that there is a loss of vision, either associated with the metastasis
Ah,
itself.
that's the connection.
Yes, it's
Got
either
it.
associated with the metastasis itself, or it can happen as a result of surgery. So when a surgeon operates, if it has to remove a part of the metastasis that is in the occipital cortex, there can be some vision loss, and you want to measure it. You want to measure it before and after the surgery to be sure that everything is fine. But how do you do it non-invasively? How can you test functional vision without sticking electrodes in the brain of the kid,
In the brain, yeah.
or without having the kid to sit through like half an hour of testing,
Yeah.
which is something that they also often don't even have the strength of doing.
Yeah.
So, and that's where we came up with and actually that's where we got the idea of having a system that allows freedom of movement, that doesn't require any manual or verbal interaction. And in the case of children, we also make the stimulus a bit more
I was
appealing
gonna
and
say, put it
interesting.
like
Yeah,
the Pikachu of the
yeah,
something like
exactly. Like
that.
now,
Yeah.
now we've been warned on. We have to be still clear for Pokemons for copyright potential
Yeah.
copyright issues. But in general, we also use ladybugs in the past, or butterflies, anything that is a bit more
Yeah.
appealing. And then the test is follow the butterfly, which it's much easier to understand.
Yeah, yeah, you could even gamify that, make it try to
Yeah,
figure
like
out a way to gamify that for the with the
like
kids.
a high
That would be
score.
yeah,
Yeah,
yeah, yeah, exactly. How many butterflies can you see or
yeah.
something? Wow, that's interesting. Yeah, neurosurgery. We work with a company, GT Medical Technologies. They make a little tile that you implant post neuro tumor resection, and it's a brachytherapy technology that radiates internally. You know, and part of their thesis is that exactly what you said. There's oftentimes adjacent critical structures that can't that cause that tumor to not be able to be removed in its entirety. And
Mhm.
sometimes, to your point, there are critical structures that are damaged in the removal or the resection of those tumors. So it's a clear indication. What's the commercial strategy and status here?
Mhm.
Tell us a little bit about that, I know you guys haven't. We won't go too deep into reimbursement because you're focusing on the EU first,
Yeah,
and
Europe market
specifically
first.
your local market.
Mhm.
But yeah, what's the commercial strategy? When could this we see this available in the
Mhm.
US?
So our commercial strategy is data first. It can be really summarized in data first.
Yep,
So this technology,
smart.
so this eye tracking technology that now you see an embodiment of the device, can actually be applicable in different contexts. We decided to start with this specific design to target the pre-hospital screening market. So actually
Hmm.
trying to create a essentially a new market for perimeters, which is the optical retails that right
Yep.
now 99% of them don't use this equipment for all the reasons that we mentioned before.
Which would provide an additional revenue stream for them.
Absolutely, yeah. That's
Yeah.
one of the line that they're going about. And actually, it's funny because if you talk to 10 different opticians and optometrists, you will get 10 different ways of monetize this application.
Yeah.
Everyone has their own idea on how it can create more revenues for them,
Yeah.
and also the amount of interest and pre-orders that we received for this thing, it's quite encouraging. For medical devices that are not yet on the market, it's not very common to receive like pre-orders. Like this is not
Yeah.
like a board game on Kickstarter. It's an actual medical device
Right.
with yeah. It's a bit weird that people are like, oh yeah, we want it. We want to be first on the
That's
line.
awesome. I
We
love to
already
hear
put
that.
down the money. As soon as it's out, please deliver it.
Yeah, I love
And
that. I love
we
that
did
because so
deliver
many
it.
people have a hard time getting commercial traction initially.
Hmm.
That tells you that you guys have a huge product market fit. The market gets it, and
It's
that's got to be reassuring.
I don't want to say anything about it, but the signs are encouraging.
Yep.
for sure. And that's our first step. And the idea is to push this product forward to collect as much data as possible. So a really widespread adoption is what we're prioritizing right now. We're not chasing after incredible profit or margins at this stage. We're really trying to keep our price point as low as possibly we can, just to facilitate the adoption of the product.
What's the ball? Can you share ballpark price?
Yeah, no, absolutely. Like the price for the pre-order is 12,000 euros,
Got it. Okay.
which roughly
Very
the same
approachable.
yeah, no, consider like the average equipment in an optician store is around 15,000 more or less, even for relatively simple things like a non-contact tonometer is
And
approximately on the same number.
what would the device that they would use, the legacy technology, what would that cost, a perimetry device?
Oh, if you like a newer one, like if you will have to buy it right now, I think the latest model of the most common and famous one is around 35K.
Oh wow.
So
Okay,
we're
so
talking
this
about a
is
factor of three, yeah.
yeah, this is significantly more approachable than
Mhm.
buying a big and that makes sense that they wouldn't have those in the optometrist's
Yeah,
office.
but
So it's
the thing is, we're also thinking of way to make it more appetizing for opticians and optometrists, because often what we receive is like, oh yeah, you have a fantastic story, it's really nice, but a lot of opticians, they say we're not really interested in health screening. It's like, yeah, no problem. You can test, for instance, the suitability of drivers for
yeah,
the driving license. That's an example. We have in the working methods for the optimization of multifocal lens design based on the visual behavior of a person. Like how they explore the environment depending on how they move their head or versus they move their eye, and then the change in the aberration zones of the multifocal lenses is dependent on this kind of behavior, which we can objectify in just a few minutes. So these
wow.
are all things that are intrinsically interesting for them, regardless of the health screening, which happens anyway because we still get the data. So we create a bit of a win-win scenario. They get like a nice tool that they can use for monetization, but also for differentiating themselves from competitors. And at the same time, they provide a really nice health service to the local population.
Yeah. What and how does it work? Does the software just automatically update? If you guys push out an update to the software, will that just automatically through Wi-Fi just download into all of the new terminals, or how would that work?
So right now the application runs on the cloud. So it's hybrid. Part of the application actually runs locally, and this is also another important thing because we have to be compliant with GDPR, not the
Right.
yeah. So all the sensitive data never leaves the device. It stays locally there, and that's actually owned by the customer. So we don't claim any ownership on the sensitive data.
Yep.
We also don't collect it. We don't do anything with that. What we take is the processed the raw processed data kind of in between, which is absolutely anonymous and impossible to
Anonymous.
interpret.
Yeah.
Yeah, it's essentially like you see, it's like a signal, like a very noisy signal. You wouldn't be able to tell anything from it. But from that we can basically
Build
derive. Yeah,
future. Yeah.
exactly. That's really the source that we're using for building this. And yeah, and then the actual application, you actually access it from a web browser. And that's
Oh
the other
wow.
cool thing. You can control this device remotely and from pretty much any device on the same network. You want to use it from your phone, you want to use it from your living room with a laptop or with a tablet, anything goes. As of course you have to have the credentials, so we have all the
Right.
authentication system in place. But yeah, you don't need to stay physically there, so you can separate also the data collection and analysis in completely different areas.
Wow. Wow, that's incredible. Wanted to, as we're wrapping up here, because I want to be sensitive to time. Just wanted to wrap up. I know you're doing a raise right now. I wanted to highlight
Mhm.
that because I think this is a technology that there'd probably, I can't imagine that you're going to have a hard time raising money for this opportunity, even in this environment. But
Mhm.
if you want to share just a little bit about kind of the raise you guys are going through right now and what you're looking to
Yeah,
put
no,
in
no,
there.
no, absolutely. So, yeah, we were quite lucky already to close a seed round in in this climate. So we closed 3 million in June. But given well, the amount of requests that we're receiving and the interest that is going on, and well, all the buzz around it. Originally, we had planned for the Series A at the beginning of 2025, but we decided to anticipate it. And the idea is now we're targeting around 10, between 10 and 15 million for this round, with the idea of expanding towards the US. So we're already doing FDA investigation. We're already MDR compliant largely with the MDR. So FDA is not going to be too much of a big challenge. And to create the evolution of this product, which is the one specific for hospitals. So, this one has been designed with pre-hospital use case in mind, and the other one would be really targeted for hospital use, with the idea of trying to become the new gold standard, which is quite an ambitious goal.
Yep.
But you have to dream big.
That's right. Yeah, dream big or don't do it. Right? Don't set
Go
forth
big or
with
go home. Yeah.
yeah, don't set forth with trying to change the world if you're not going to really try to change the world. So, no, that's fantastic. Well, yeah, we've talked several times in the past now, and I think the world of what you guys are doing, and wish you continued success. Excited to see it roll out in the EU. Can't wait to see it come here to the US. And best of luck with closing this round and making that happen. I
Yeah.
guess
Thank
the
you.
last thing I would say is for those out there that are interested in potentially investing or potentially working with a great organization like Reyedar, what's the best way for folks to reach out to you?
Definitely by email. No, email and LinkedIn are the things that works best for me. Also because calls, I'm in calls most of the time. It's sometimes quite difficult to reach me by phone, and especially if you're working on different time zones, asynchronous communication is the best. Right now, I'm working on 4 different time zones, like the East Coast, the European one, India, and Japan. So
Oh yeah.
it's quite complicated to manage everything. So
Yeah.
email definitely is the best.
Okay, we'll get that posted in the show notes if you want. Otherwise,
Absolutely, yeah.
folks can reach out to you through LinkedIn. But thank you again, Alessandro. Wishing you continued success, and we're excited to have you back on the show once you hit a couple more of these milestones, and we can do a
I would
recap
love that.
show.
Yeah, thanks a lot, Mike, for having me. It's always a pleasure. Whenever you want to have a chat about eye and brain, the door is always open.
You got it. Well, that's it for this edition of the Bleeding Edge of Digital Health. Look forward to catching you guys on the next episode.